Good morning and welcome to this meeting of the Physician-Focused Payment Technical Advisory Committee, known as PTAC. Welcome to our first ever virtual public meeting. We've been working very hard over the last few months and chose to hold our meeting virtually rather than further delay evaluating submitted proposals. We will begin that work later on in our agenda, but first, we're very excited today to be joined by the administrator of the Centers for Medicare and Medicaid Services, Seema Verma. In her role as the administrator, she oversees a $1 trillion budget, representing about a quarter of the total federal budget, administers health coverage programs for more than 130 million Americans, and oversees the quality and safety for all providers participating in Medicare. Nominated by President Trump on November 29th of 2016, the seventh nomination by the President-elect and confirmed by the U.S. Senate on March 13th, 2017, she is one of the longest serving administrators in modern history. Administrator Verma is a graduate of the University of Maryland and holds a master's degree in public health from Johns Hopkins University. Modern Healthcare ranked her as the #1 most influential person in healthcare in 2019. And with that, it is my pleasure to welcome Administrator Verma.
Thank you, Jeff. I appreciate the introduction, and thank you all for joining us virtually today. I'm excited to kick off a new phase of partnership between CMS and PTAC. Before we get into value-based care, I'd like to take this opportunity to talk about CMS's response to the coronavirus pandemic and how we're responding in the context of value-based care. First of all, I want to extend my sincere gratitude to everyone on the front lines of this crisis. Caring for both the physical and mental health is challenging at a time like this, and America is grateful for our frontline workers and their service. Those of you that have been working around the clock in that capacity deserve every ounce of support that we can muster. And that's why at CMS we've been working to provide healthcare workers with the tools that they need at this unprecedented time. During the pandemic, CMS has expanded flexibility across the board, and the first and best example of this is telehealth. Telehealth has been nothing short of a lifeline. It's allowed seniors to access care that they need without leaving their homes and risking potential exposure to the virus. And it's also protected healthcare workers and preserved PPE. We've increased access to telehealth visits, including by expanding the types of telehealth visits we cover, and never before has the health system adopted so rapidly to any change, especially one that so dramatically transforms how care is delivered. Since mid-March, nearly 7.3 million Medicare fee-for-service beneficiaries have used telehealth, and that's up from approximately 136,000 from January to mid-March, an over 4,000% increase. And we continue to hear very positive feedback from both providers and patients. And we've also removed regulatory barriers so that members of the healthcare workforce can practice at the top of their license, consistent with state laws. This effort was ensuring that health systems across the country could have all hands on deck. And we've allowed physicians affiliated with hospitals to provide care in places like skilled nursing facilities and inpatient rehab facilities. And we've also changed some of the requirements for nurse anesthetists. Under the CMS's Hospitals Without Walls initiative, we've taken multiple steps to allow hospitals to provide services in other healthcare facilities and sites that aren't necessarily a part of the physical existing hospital, and to set up temporary expansion sites to address patient needs. For example, ambulatory surgery centers with capacity can register as hospitals for the duration of the emergency and receive comparable compensation. And we've also changed our testing policies. So we're allowing labs to go out to nursing homes to collect samples, and we've also expanded access to testing in pharmacies. And finally, we have lifted scores of regulations across the board to help our health systems and provide more flexibility, anything from just removing some of the reporting requirements to give our systems more flexibility. And we're also working hard to support states as they seek to use new tools available to them in order to respond to the pandemic. CMS has approved over 365 requests from states for waivers, amendments, and flexibilities in Medicaid state plans, and most of these were done in a matter of days. When it comes to our existing payment models, we have announced important flexibilities on implementation dates, as well as data reporting requirements to ensure providers can focus on patients instead of paperwork during the pandemic. We've also made adjustments to payment methodologies, including mitigating risk during the emergency and modifying cost targets and benchmarks to adjust for the response to the virus, so providers aren't at risk for costs solely due to this unprecedented pandemic. And you're going to hear more about this from Brad Smith later on today. And of course, this just scratches the surface. We continue to solicit feedback from providers such as you, and we have ongoing meetings, weekly meetings with provider types across the board. And as we reopen the country, we are considering the impact of these flexibilities and what should be a permanent part of our Medicaid and Medicare programs. And some of those changes will require Congress to act, but we are looking at what we can do through our regulations as well. I've been very clear that I think that telehealth and the flexibilities around telehealth should be maintained. And as we assess the changes made to our programs, we will also be looking at the flexibilities we offer in alternative payment models and how to continue to encourage value-based care. This crisis brought to light numerous vulnerabilities in our healthcare system, including how a fee-for-service payment in a time of falling non-COVID demand left many providers with serious revenue declines. By contrast, alternative payment models such as population-based payment models may buffer such abrupt revenue losses. And as you know, improving value is a top priority at CMS, a central plank of our agency-wide agenda. We want to deliver high-quality outcomes at the lowest cost. A major component of the transition to value-based care is the models we develop and release. The process of crafting a model is complex and requires significant investment of time and resources. PTAC plays a vital role in our development of these models by providing practical, well-vetted input, and we are deeply grateful for that. And conversations with submitters who have gone through the PTAC process have informed and enriched our thinking on these issues. Going forward, we want to continue to hear from stakeholders on what they believe to be care delivery issues and how they think we can use value-based care to address those issues, especially after their experiences during the public health emergency. And we want to leverage PTAC as the place to gather valuable public input on provider adoption of alternative payment models. Boosting participation in our existing models and future ones that we plan to release is a top priority. Right now, the application for direct contracting is open, and the Primary Care First and Kidney Care Choices model applications recently closed. We expect that these new models will bring in many new providers to value-based payments and alternative payment models when they begin next year. And we look forward to providing additional opportunities as more models are announced. Again, this year, we will be reviewing a lot of the models that started at the beginning of CMMI are now coming to fruition in terms of their evaluations, and we'll be taking a long look at the results of these early models and try to apply lessons learned to the models that we develop in the future. So thank you again for being here. Your willingness to take time out of your busy schedules to serve the American people and its mission to improve the health and well-being is invaluable. And so thank you and have a wonderful conference.
Thank you, Administrator Verma. And welcome. My name is Dr. Jeff Bailett. I'm the chair of the PTAC committee, and we're incredibly thankful to the administrator for joining us and giving us her public remarks. We appreciate you taking the time out of your very busy schedule to articulate your vision for this renewed sense of cooperation between PTAC and CMS, and we are here as eager and willing partners. I would like to welcome members of the public who are participating today, whether it be WebEx, phone, or live stream. Thank you all for your interest in today's meeting. Should you have technical questions during the meeting or decide you would like to make a public comment on one of the proposals during the meeting, please reach out to the host via the chat function in WebEx or email, or call PTAC at the registration staff, PTAC registration staff per your logistics email, and your name will be added to the end of the pre-registered list of commentators for the specified proposal. You can also email PTAC registration at norc.org with any questions. Again, that's PTAC registration at norc.org. We extend a special thank you to the stakeholders who have submitted proposed models, especially those who are participating in today's meeting. We recognize that many PTAC stakeholders are directly involved in responding to the pandemic, and we are grateful for your service to our communities across the nation, especially to those on the front line. We're also thankful for the privilege of your time and attention today. PTAC has long been committed to supporting a submitter-driven process, and we recognize that our stakeholders and potential future submitters may have their focus directed in other areas presently. So I would remind anyone who's considering submitting a proposal that PTAC accepts proposals on a rolling basis, so you don't have to worry about submitting a proposal within a certain timeline. In addition to the frontline providers, we also want to thank the multitude of other providers, support staff, caregivers, family members, and others supporting patients during this crisis. This pandemic has highlighted many challenges within our healthcare system that we knew existed to varying degrees, but really were brought to the forefront, the inconsistent resilience of our healthcare system and the many gaps that exist. Some involve payment reform and clinical redesign, work that is the focus of the models PTAC is evaluating and can play a significant role in addressing. This public health emergency has taught us much about our current fee-for-service system, and that value-based alternative payment models, as the administrator has said, can play a significant role in addressing those weaknesses. In a fee-for-service system, providers must rely on their patients' ability to present for appointments and procedures in order to support their financial business model. The pandemic challenged this delivery structure with a sudden, staggering decline in revenue for many types of providers across the country. A variety of alternative payment methodologies, such as capitation or value-based payments, offered providers continued revenue in the face of declining patient visits. Alternative payment models are an important part of healing the healthcare system, accentuated during this crisis, as are other key solutions that have played an important role in supporting patients and providers, such as telehealth. Now is most certainly an important time for PTAC to ensure that our processes and approach to model evaluation are well designed to encourage stakeholders to engage with us to strengthen the resilience of our healthcare system. In addition to submitting proposals for alternative payment models, we are exploring new ways of sharing your ideas with the committee that will be announced in the coming months. Although today's meeting is being held virtually, PTAC members are actively engaged, participating from their various parts of the nation and eager to hear from our submitters today. While our goal is for a seamless virtual experience, the potential exists for technical challenges such as sound delays or background noise, so we appreciate your understanding should such challenges arise. I want to note that this is PTAC's 10th public meeting that includes deliberations and voting on proposed Medicare physician-focused payment models submitted by members of the public. PTAC has been working hard since our last public meeting in September, and I would like to walk through some of that work before we begin our deliberations. First, I would like to introduce our newest PTAC member as we begin. Dr. Charles DeShazer was appointed by the U.S. Government Accountability Office in October of last year. He is an internist by training who joins us from Highmark Health Plan in Pittsburgh, and we are pleased to have him serving on the PTAC committee. Welcome, Charles.
Thank you.
We are expecting 3 new appointments to PTAC in the coming weeks, and we will be sure to welcome those new members at our public meeting, at our next public meeting this September. I would also like to take a moment to reflect on the work of PTAC and how it has evolved over time. PTAC was created within the Medicare Access and CHIP Reauthorization Act of 2015, known as MACRA. The first phase of the committee's work involved many public meetings where we sought public feedback about how best to design the committee's proposal review process. We also attended briefings about the government's work in the alternative payment model space. The Secretary of HHS then released the MACRA final rule, which included the 10 criteria we were to apply to our review of proposals. In December of 2016, we began receiving proposals from the public for physician-focused payment models, moving us into the next phase of our committee's work. We have received 36 models, delivering reports to the Secretary on 24 of them. Each report represents significant effort by the submitters, drafting the proposal and the committee in its subsequent review. PTAC has been receiving models for 3.5 years, long enough that we wanted to reflect on the different models we've reviewed, including evaluating who has submitted ideas, what payment and care delivery issues have they identified across the healthcare system, and what solutions have been proposed. To this end, ASPE's contractor, NORAC, has compiled 2 reports that summarize and provide an inventory of the proposals that have been submitted and the extensive evaluating reviews provided by PTAC. You can find these reports on the ASPE PTAC website at the top of the resource page. The first report highlights themes and common elements across proposals regarding issues targeted and the proposed solutions. The second report describes patterns in how PTAC has assessed the proposals that have been submitted to the committee. Taken together, the reports provide a comprehensive look into the breadth, objectives, and variation of alternative payment models submitted by stakeholders and the findings derived from the committee's analysis of the proposals relative to the Secretary's criteria. I believe these reports synthesize the extensive evaluative work conducted by our committee as we review the proposals designed to address important issues in healthcare delivery as raised by stakeholders in the field. These combined efforts can inform stakeholders who may want to submit proposals to PTAC, policy developers, the PTAC itself, and the public at large. Later today, after we have voted on the 2 proposals, the contractor will offer a short presentation on these 2 reports that I think you'll find very interesting. Looking to the future, we reflected on the history and the work of PTAC, taking into account the tremendous and important stakeholder input on care delivery and alternative payment models. We want to incorporate these reflections to further activate and encourage stakeholder engagement. As we continue to evolve our work as a committee, we drafted a vision statement to better communicate to the public how our work fits into the transition to value-based care. I would like to read that statement now. PTAC was created to contribute to a national priority to improve the efficiency and effectiveness of the U.S. healthcare delivery system. We believe that proposed solutions from frontline stakeholders in our delivery system can substantially enhance quality, improve affordability, and influence policy development and system transformation. PTAC provides a forum where those in the field may directly convey both their ideas and their concerns on how to deliver high-value care for Medicare beneficiaries and others seeking healthcare services in our nation. PTAC is committed to ensuring our stakeholders have access to independent expert input and their perspectives and innovations reach the Secretary of Health and Human Services. PTAC will continue to submit comments and recommendations regarding physician-focused payment models submitted by stakeholders to the Secretary as required by statute. In addition, we will expand our communications with the Centers for Medicare and Medicaid Services, CMS, and stakeholders to identify our opportunities to further inform and prioritize the work CMS, including the Center for Medicare and Medicaid Innovation, CMMI, and other policymakers are undertaking to modernize healthcare. This statement serves as the framework for for other changes you will see both today and in the future. We want to remain thoughtful and leverage collaborative opportunities that encourage stakeholders to provide their ideas on how to address care delivery challenges through expanding value-based care. We also want to broaden our knowledge foundation, including gathering information through public dialogue on various cross-cutting themes and topics raised across proposed models, such as telehealth. We believe such input will serve to better inform our recommendations to the Secretary. Also, shortly we're releasing an updated version of our proposal submission instructions that are designed to expand the number of and types of proposals that are submitted to PTAC. We have found that while certain proposals may have strengths within some criteria and weaknesses in other, when evaluated as a whole, these proposals may raise important care delivery, payment, or policy issues. Therefore, PTAC encourages stakeholders to submit physician-focused payment model proposals that address the innovative approaches in care delivery, regardless of the level of sophistication of the payment methodology. These updated instructions reflect the committee's vision to encourage engagement and to activate stakeholders who wish to convey care delivery and payment challenges along with proposed solutions. We are eager to elicit real-time input to help inform the committee about specific issues stakeholders are experiencing in the field. We hope that these new instructions will encourage more submissions. As the vision statement expresses, submitting to PTAC is an opportunity to help inform the policy community about what you have experienced on the front lines and suggest potential approaches to address any issues. In addition, these efforts, we are looking forward to having theme-based discussions during future public meetings to foster dialogue and insights on specific broad-based challenges whose impacts are not limited to a single proposal. These discussions will occur in addition to the current deliberative public process, which happen after proposals on any topic have been reviewed by a PTAC preliminary review team and then by the full committee. I want to be very clear that we will continue to accept all proposals on any topic at any time. PTAC is always open for business. We are hard at work preparing for our first theme-based discussion, which we are hoping to hold in September, and this will be, focused on telehealth. Included in this session will be holistic reflections on previous proposals that included elements related to telehealth, tying together how alternative payment models in telehealth may play a more important role as features that can further transform our healthcare system. We also intend to invite public input on this topic in the future, as well as continue to evaluate submitted proposals that are ready for deliberation, as has been done in the past. As today's comments convey, your input is very important to us. In addition to the efforts I just shared, at the end of the day, we will pose some questions about challenges in care delivery, payment model design, and other important challenges members of the public are experiencing. A detailed list of these questions will be posted on the ASPE PTAC website. Comments by email will also be accepted. Your input will inform our future work, and we will report out the comments received related to this inquiry at a future public meeting. Together, all these efforts just described serve to further inform PTAC's work and help enhance our efficiency and effectiveness on behalf of the stakeholder community and the beneficiaries they support as we continue to evaluate alternative payment and clinical redesign models. As a reminder, in order to receive updates about these various opportunities to engage with PTAC, please join the PTAC listserv, which you can find on the contact page of the ASPE PTAC website. Moving on, PTAC published a report to the Secretary with our comments and recommendations on the proposal entitled Access Telemedicine, an alternative healthcare delivery model for rural cerebral emergencies that we deliberated and voted on last September, which had been submitted by the University of New Mexico Health Sciences Center. Our preliminary review teams have also been working hard to review multiple proposals, two of which we are scheduled to deliberate and vote on today. To remind the audience, the order of activities for review of a proposal is as follows. First, PTAC members will make disclosures of any potential conflicts of interest. We will then announce any committee members not voting on a particular proposal. Second, discussions of each proposal will begin with a presentation from the preliminary review team, or PRT, charged with conducting a preliminary review of the proposal. After the PRT's presentation and any initial questions from PTAC members, the committee looks forward to hearing comments from the proposal submitters and the public. The committee will then deliberate on the proposal. As deliberation concludes, I will ask the committee whether they are ready to vote on the proposal. If the committee is ready to vote, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. After we vote on each criterion, we will vote on our overall recommendation to the Secretary of Health and Human Services. And finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments they would like to include in PTAC's report to the Secretary. A few reminders as we begin discussions of today's first proposal. First, if any questions arise about PTAC, please reach out to staff through the PTAC@HH.gov email. Again, that email address is PTAC@HHS.gov. We have established this process in the interest of consistency in responding to submitters and members of the public and appreciate everyone's cooperation in using it. I also want to underscore three things. The PRT reports are reports from 3 PTAC members to the full PTAC and do not represent the consensus or position of the PTAC. Second, PRT reports are not binding. The full PTAC may reach different conclusions from those contained in the PRT report. And finally, the PRT report is not a report to the Secretary of Health and Human Services. After this meeting, PTAC will write a new report that reflects inputs from the public as well as PTAC's deliberations and decisions today, which will then be sent to the Secretary. PTAC's job is to provide the best possible comments and recommendations to the Secretary, and I expect that our discussions today will accomplish this goal. I would like to thank my PTAC colleagues, all of whom give countless hours to the careful and expert review of the proposals we receive. Thank you again for your work, and thank you to the public for participating in today's first ever virtual meeting. Let's go ahead and get started. The first proposal we will discuss today is called Care Emergency Department Avoidance. This proposal was submitted by the University of Massachusetts Medical School. PTAC members, let's start the process by introducing ourselves and at the same time, read your disclosure statements on this proposal. Because this meeting is virtual, I will prompt each of you. I'll start. Jeff Baylett, CEO of Alteus, nothing to disclose. Next is Grace.
Grace Terrell, CEO of Aventus Whole Health, nothing to disclose.
Paul.
Paul Casal, cardiologist and executive director of New York Quality Care, the ACO for New York Presbyterian, Columbia, and Weill Cornell. Nothing to disclose.
Charles.
Charles DeShazer, Chief Medical Officer for Highmark Inc. Nothing to disclose.
Vida.
Kavita Patel, internist and fellow at the Brookings Institution, nothing to disclose.
Angelo. Angelo may be on mute.
Well, sorry. Angelo Sinopoli, a pulmonary critical care physician and chief clinical officer for Prisma Health in South Carolina.
Bruce.
Bruce Steinwald, a health economist here in Washington, D.C. Nothing to discuss.
And finally, Jennifer.
Jennifer Weiler, Chief Quality Officer, UC Health, Denver Metro, and Professor, University of Colorado, School of Medicine in Denver, Colorado. Nothing to disclose.
Thank you. I would now like to turn the meeting over to the lead of the preliminary review team for this proposal, Dr. Paul Cassell, to present their findings to the full PTAC. Paul?
Thank you, Jeff. Before I get started on the presentation, I wanted to state that Harold Miller, who, as you can see, was a member of the PRT for this proposal, he resigned from the PTAC on November 19, 2019. He did participate in the PRT, and his input is reflected in the report that is about to be shared. Next slide. Next slide. So just as a reminder how PRT works, the PTAC chair and vice chair assigns 2 to 3 PTAC members, including at least 1 physician, to each complete proposal to serve as the PRT. The PRT identifies additional information needed from the submitter and determines to what extent any additional resources or analyses are needed for the review. The PRT determines at its discretion whether to provide initial feedback on a proposal. After reviewing the proposal, additional materials are gathered and public comments received. The PRT prepares a report of its findings to the full PTAC. As Jeff already mentioned, the PRT report is not binding on PTAC. PTAC may reach different conclusions from those contained in the PRT report. Next slide. So some background on the EyEDA proposal. It's based on a Transforming Clinical Practices Initiative award, assisting over 1,600 optometry practices across the U.S. to increase the number of patients with eye-related symptoms who make visits to a practice rather than an emergency department for urgent eye conditions. The submitter asserts this approach improves the quality of care for patients and reduce the cost of treating urgent eye-related conditions for both payers and patients, because the payment for an office visit is significantly less than the payment for an ED visit. The goals of EyEDA proposal is to encourage treatment of selected eye-related symptoms through office visits with optometrists and ophthalmologists rather than visits to hospital EDs. The alternative payment model entity are licensed optometrists and ophthalmologists, as well as organizations employing optometrists and ophthalmologists. Next slide. The core elements of the proposal of financial risk is in the form of an 8% reduction for all urgent care visits. These are identified by ICD-10 diagnoses codes relative to payments under the normal physician fee schedule. Shared savings payment at the conclusion of the performance years based on the participating provider or practice's number of qualifying urgent office visits relative to a target level, and the reduction in ED visits in area hospitals for the same diagnoses relative to a base year period. Performance on 2 quality measures are also taken into account: patient experience and patient safety. These are a quality threshold in order to participate in the model and receive shared savings payments. Next slide. The 8% reduction for initial office visits will be for specified ICD-10 codes in the categories of ED avoidable conditions such as conjunctivitis, corneal injury with a foreign body, STI, acute posterior vitreous detachment, eye pain, and other eye conditions. The submitter believes that the number of patients making urgent care visits to the practice instead of the ED will increase by educating patients about the desirability of receiving urgent eye care from optometry or ophthalmology practices, and by expanding the office hours for those providers. The proposed model does not, however, require that participating practices use any specific approach to encourage these visits. Next slide. In terms of the payment model, in order to receive shared savings bonus payments, providers must meet minimal thresholds on the 2 quality measures. They include patient experience, assessed through a patient survey, and patient safety, which is defined as the 7-day adverse event rate for the ICD diagnosis codes for which they were seen. Adverse events include unscheduled ED visits, hospital admissions, or observation stays, blindness or permanent visual impairment, or death. The target number of visits for each participating practice or provider would be developed based on historical volume of visits for these conditions, which would then be increased by some percentage. Participating practices or providers could receive shared savings payments if there are a reduction in ED visits for the proposed urgent eye-related conditions. The proposal does not specify the percentage of the savings that would be shared or the method for identifying the service area. Each participating physician or practice would receive a share of the savings for distribution based on the increase in urgent care visits at that practice as a percentage of the total increase in urgent care visits across all participating practices. Next slide. The experience with the TCPI program provided technical assistance, as I mentioned, to over 1,600 optometry practices nationwide from October 2017 through May of 2019. Optometrists enrolled in TCPI reported more than 330,000 visits to the ED were avoided through same-day office-based appointments and after-hours triage. These reports were based on ICD-9 codes for office visits rather than tracking of changes in ED visit rates. Feedback from TCPI provider participants indicates that many of these optometrists would participate in the EyEDA model. So summarizing the PRT review is seen here. What I'll do, rather than walking through this slide, I will go through each of the criteria in detail. Next slide. The key issues identified by the PRT. The 8% reduction in fees for urgent care visits may discourage participation and cause problematic financial losses for practices that cannot successfully meet targets for increased number of visits. Payment is still fee-for-service based on office visits, with no flexibility in payment to support different approaches to services. Payment reductions and visit targets tied to specific diagnosis codes could result in undesirable incentives to code incorrectly. The model does not attribute patients to practices. The methodology for determining shared savings and attributing the savings to participating providers is not clearly defined. The proposed model does not require or encourage care coordination with primary care providers or other specialists. And many of the problems with the payment model arise due to challenges that the submitter faces in trying to craft a model to meet the requirements that CMS has established for an advanced APM. Next slide. So for criteria 1, scope, which is a high priority, the PRT conclusion was does not meet. This was a majority conclusion. In reviewing this criterion, no alternative payment models in the CMS portfolio specifically address eye-related conditions or focus on care delivered by eye specialists. So that was one of the considerations in regards to scope from a provider point of view. Specialty participation in APMs is important, but should broaden existing opportunities. The particular clinical issue of urgent eye visits might be appropriate in a broader risk-based model, such as an ACO or bundled payment model, as opposed to a standalone model. The model narrowly focuses on changing the site of treatment for one particular set of health problems, rather than taking a more holistic approach to the patient's needs. And finally, ED visits for eye-related conditions occur primarily among those under age 65. It's not clear if practices would be able to increase their provision of urgent care in the office if the model is not implemented for more payers beyond Medicare. Next slide. Criteria 2, quality and cost, also a high priority criteria. The conclusion from the PRT is that it meets criterion. This was unanimous. Treatment of patients in an office-based setting for the proposed eye conditions rather than an ED, when appropriate, would reduce costs for both payers and patients. Increase access to care in the most appropriate setting would potentially improve healthcare quality. The model includes 2 quality measures designed to ensure that urgent conditions receive high-quality care in an office setting. However, the proposed measures have limitations that may not adequately ensure the highest quality care. Patient satisfaction does not necessarily ensure that a condition was treated in the most appropriate way. The patient safety measure captures only adverse events that occur within 7 days and only those related to the same ICD-10 diagnoses as the original office visit. The rate of adverse events is unlikely to be a statistically valid measure for small practices. And finally, some conditions may not represent urgent needs, but instead are emergencies that cannot be safely treated in an office setting. Next slide. Criterion 3, payment methodology, also a high priority. The PRT conclusion was that it does not meet the criterion. This was unanimous. The proposed payment model would provide a strong financial incentive to increase the number of urgent care visits for eye conditions. However, the approach to setting performance targets raises concerns. It would penalize practices whose patients already come to them for urgent care needs, and small practices could have a low or high baseline rate based on random variation. The proposal does not require any mechanism to document the nature of the presenting symptom or to identify the reason the visit should be deemed urgent. The shared savings calculation is based on a reduction in ED visits without attributing the reduction to participating practices. The proposal does not specify how adjustments would be made when eligible patients in the service area change over time. And finally, the proposal does not provide any upfront payments to support the ability of participating patients to deliver more and better urgent care. Next slide. Criteria 4, value over volume. The PRT concluded that it meets this criterion and was unanimous. The proposal creates an incentive for optometry and ophthalmology practices to encourage patients to come to their office for urgent care needs, which would likely decrease ED visits for eye-related conditions. The proposal includes a measure indicating whether the ocular problem was resolved and also tracks satisfaction in adverse events. However, the small size of many practices will make statistically appropriate assessment of adverse event rates problematic. Payments for urgent care services and targets are still tied to office visits with the physician, so practices would not have the ability to address urgent needs through phone calls, emails, or non-physician staff. Finally, the model forces practices to increase the number of office-based visits in order to offset payment cuts and meet visit targets, even if more visits are not needed. Next slide. Flexibility. The PRT conclusion was that it met the criterion for flexibility, and this was a majority conclusion. The proposal would reward optometrists and ophthalmologists for changes in their care delivery processes in order to better respond to patients with urgent eye conditions without dictating how the practices should do this. However, the proposal does not fundamentally alter the fee-for-service structure of payment for eye visits. Providers would be paid only for office visits, not for phone calls, emails with patients, even if those services could resolve the patient's needs, and not for care management or other education activities that would help patients avoid developing eye problems. The 8% reduction in visit payments and an uncertain shared savings payment would make it more difficult for practices to provide services that do not qualify for fees. Next slide. Criterion 6, ability to be evaluated. The PRT conclusion was that it met this criterion, and the conclusion was majority of the PRT. The proposal's primary performance measure is quantifiable and could be compared with other providers. The information is systematically collected through claims across providers and over time. The proposal uses standard ICD-10 codes to identify urgent visits, so the same definitions of eligible visits could be used for non-participating providers. The adverse event metric could also be determined from claims for participating providers and compared with non-participating providers. To compare patient experience and satisfaction between participating providers and non-participants, patient survey data would have to be collected from a comparison group of patients who see non-participating providers. The lack of attribution of patients or ED visits avoided to participating providers could make it difficult to evaluate whether changes in ED visits were different between participating and non-participating providers. Next slide. Criterion 7, integration and care coordination. The PRT conclusion was does not meet criterion. and this was a unanimous conclusion. The submitter reported that eye care specialists informally make referrals among themselves and to other providers to ensure appropriate care. However, participating providers would be encouraged to see patients for urgent care needs, even if they are not the most appropriate provider to treat the condition. There are no formal methods for integration with primary care physicians or other providers who may be initiating treatment or treating a patient. Next slide. Criterion 8, patient choice. The PRT conclusion was that it meets this criterion, and the conclusion was unanimous. The proposed model would make it easier for patients to receive appropriate treatment for urgent eye conditions outside of a hospital ED. It is possible that a beneficiary might not realize that they have the right to seek care in another setting, such as an ED, even if their optometrist or ophthalmologist presents them with access in the office setting. Next slide. Patient safety. The PRT conclusion was it does not meet this criterion, and it was a unanimous conclusion. The proposed measurement of adverse event rates and patient satisfaction scores would help to ensure that eye problems are being addressed appropriately during the urgent care visits. However, the proposed diagnosis codes cover a broad range of eye conditions, some of which are much more clinically serious than others. Patients do not know their diagnosis when they seek care for an eye condition, only their symptoms. The same symptoms, such as eye pain, impairment of a visual field, or redness, can result from conditions across a wide range of clinical severity, not of all which are appropriate for care by an optometrist or in an office setting. As a result, patients who need care in the ED may not receive it, which has the potential to harm patient safety. Next slide. The final criterion, criterion 10, health information technology. PRT conclusion was that it met this criterion, and the conclusion was unanimous. The TCPI project on which the proposal is based led providers to use electronic health records more extensively. If implemented well, the proposal could encourage providers to use technology to a greater extent to inform care. There is potential for providers to incorporate telehealth services to expand access and achieve the proposal's objectives. However, the proposed model does not explicitly require or encourage enhanced use of health information technology. Next slide. So with that, Jeff, I thought I would turn it over to Kavita for any additional comments she may have on the discussion amongst PRT.
Thanks, Paul. It's Kavita. I just wanted to just reinforce kind of the process that we use because as Paul mentioned, we had 3 of us on the preliminary review committee and found our interactions with the submitters and in all the deliberations kind of back and forth on the review team very engaging. And despite it being kind of pre-COVID, I feel pretty confident that we can have a great conversation now, and wanted to thank Paul for leading the committee, as well as acknowledge Harold's important input and the submitter's time to propose this important model, and hopefully we can answer any questions from the committee as well.
Thanks, thanks, Kavita, and thank you, Paul, for leading the PRT. Before we have the submitters provide their statements and make themselves available for questions, I just wanted to turn it over to other committee members that may have questions of the PRT, Kavita or Paul, for clarification prior to bringing up the submitters. All right.
I got a question, Jeff. This is Grace.
Go ahead, Grace.
Yeah, my question is related to some of the public commentary back. In fact, some of the criticism back that was, I believe, from one of the associations related to emergency physicians, where they were concerned about many of the types of diagnoses that were listed as being ones that were appropriate within the setting of an urgent care. And I was wondering if there was any work done either with the background information that was done by our contractors or otherwise to look into that as being something that was a concern that needed to be taken into account or not, because there was a huge number of diagnoses that were listed as being potentially appropriate that looked appropriate to me as far as I could tell, but there was some concern from some of the outside public, and I'm just wondering how you all thought through that.
Yeah, we did have a discussion around that, and I'll ask Kavita to comment as well. And I think, yeah, it is a very long list, and many of them appear appropriate for the office setting. I think some of the concern was that there are, within that group of conditions, some that require, obviously, emergent care, and that the patient may not be in a position to distinguish that, and that for some of those particularly time-sensitive conditions, being seen in an office setting rather than the emergency room may lead to adverse outcome.
And the only thing I would add, Grace, there wasn't any. We just basically had kind of a more transparent discussion. I believe it's probably somewhere in our transcription minutes with the submitter. But just to emphasize that part of the acknowledgement of this was because of this work starting in the TCPI program, that there was definitely kind of a more, I would say, hub and spoke model, so that there was kind of an academic hub with spokes. You know, this wasn't just kind of the idea where this kind of started from came from having kind of ED physicians and also having kind of urgent care and ophthalmologists and having an interdisciplinary approach. And that was something that we brought up, that while that seems like an incredibly robust model that was kind of worked out through TCPI, that may not necessarily scale. However, it would be something, I think, in our comments to the Secretary's report, no matter what the voting is, that looking at that model would be critical, because it did offer something that was valuable to training, you know, in the setting of ED physicians as well as urgent care physicians.
This is Bruce. I have a question.
Go ahead, Bruce.
I'm curious about the proportion of emergency events that could be addressed through the model in the physician's office as opposed to the emergency room. The proposal states that patient education and expanded hours are going to be the principal means of encouraging more patients to see providers in their office. And yet, a lot of these events occur at evening hours and weekends. And I guess I'm curious as to what proportion of those events, like a foreign object in the eye, could actually be seen in the office when these events often occur during times when there's not unlikely to be office hours.
Well, I think we would look at the experience they had in the TPCI model, in which they saw over 330,000 visits. I don't believe, maybe I don't really believe there was data around the time of day for those visits that I recall. But you're right. I think we recognize that as one of the concerns in terms of the education and expanding hours. I mean, expanding hours will certainly help. Education might, but as you said, even if these happen during the day, having easy access, it would be critical. But to your original question, I don't remember if there was. I don't recall we had data around the time of day that these occurred.
I don't either. It'd be good to ask the submitters that.
This is Jeff. I had a follow-on question, Paul. It sort of follows on to Grace's initial point. Academy of Ophthalmology made reference again to the long list, and I think that is something that is in the process of being reviewed and potentially pared back. But there was also some comments just about the safety, creating or conveying a message to patients that for some of their eye complaints, urgent eye complaints, that they could be seen in an office rather than present to the emergency room. And there were some strong statements both from the Ophthalmology Society and also from even the Optometry Society as well. And I saw some back and forth in the responses from the submitters to your PRT. Where does that sit? And we can get a further clarification from the submitters themselves. But there seemed to be a reference that sort of contention between those two bodies had sort of got ironed out between the submitters. Is that in fact true, Paul?
It's not clear to me that it's been ironed out. I think they would turn to the TCPI project and sort of the experience they had there. And again, I would be interested to hear directly from the submitters because particularly from the ophthalmology letter also raised this question of safety. But again, I think from the material, from the TCPI project and from the experience they had there were, again, I think that the submitters felt that this model was safe for the overwhelming majority of patients who would come present with eye symptoms.
Paul,
Thanks.
This is Angelo. I'm sorry.
No, go ahead, Angelo.
Is there any discussion during this around the potential for some virtual real-time triage to make sure patients got directed to the appropriate level of care?
Well, I think we brought that up in terms of our concern that really it's all office-based fee-for-service in terms of how this payment model would potentially work was all sort of focused around office-based. So, I think we had some discussion around it, but we didn't, other than some suggestions as we put in our report that both from a triage and management point of view, virtual care would potentially offer some benefits. But that I think was the extent of our discussion.
Great. Any other questions?
Yes, this is Charles. I just wanted to follow on to that too, because that wasn't clear to me. Are there strategies embedded within this model to kind of get, I think, to Angelo's point as well, to get to a more proactive approach and being a more flexible way of interacting with your patients, because I do see that as being part of the challenge also, and a part of this is going to be changing care-seeking behaviors of the patient. And I was just wondering if there were thoughts around how you would, create that within this model, how that would support that.
Yeah, again, I think it's a really good conversation with the submitters. I think, again, because the payment model is really based around the shift from ED visits to office visits, again, so that's sort of, so to your point and Angelo's point, and certainly in the current era that we are in, where we're seeing, back when we first reviewed this or looked at this back in September, virtual care was in a very different place. But having that been, even with that said, you would see that there would be opportunity here. But again, I think ultimately the payment model was focused more around office visit, ED visit.
Good. Got it.
Anyone else from the committee have any questions before we move on? Okay, hearing none, let's go ahead and have the proposal submitters join us.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.